get with the introduction to spine coding. How many folks are doing their own coding? Anyone from amongst the residents? I see Megan is nodding no. I can see Robert there. Robert, you doing your own coding? Robert is. Let's see who else I got here.
Relatively new, yeah.
Nicholas, you coding?
Not yet, sir. No.
All right, Joseph.
No, I'm not.
Okay, Sarah.
No, sir.
Okay, is anyone coding? How about this? Answer if you're doing your own coding. All right, so here we go. This is going to be a whirlwind tour, and this is the beginning. I can tell you that I am learning something every time I go to teach a coding course. I'm going to be learning something from someone. So these are my disclosures, which have absolutely nothing to do with the talk. I want to demystify the whole coding process. We're going to talk about some ICD-10 codes, because part of getting at some point, you guys will be finished with residency. You're going to walk into your first clinic. Your your surgery schedule is going to want the ICD-10 codes. That's going to allow you to have a seamless prior authorization so that you can get your surgery approved. You're going to want to make sure you have the diagnosis correct, and you want it just to be as clean as possible. The other reason that this is very important is because this is now part of your ABNS submission. And let me tell you, 25% of case logs get returned because of coding anomalies, where there's a 22853 and the x-rays don't show any interbody. And if that happens, it can go back for systemic review. And these are things that you just don't want to be dealing with. Okay, so what are the common cervical diagnosis codes? I mean, these are not, the goal here is to demystify. So cervicalgia is the weakest of them all. You never want to use that code, but you have spondylosis, right? So cervical spondylosis is a common one. Radiculopathy is a very relevant one for what we're doing. You have cervical stenosis. Myelopathy is obviously a very important one. Spondylolisthesis, a slip of one C3 on C4. I was just looking at a lady, I'm still in clinic over here, kyphosis. So let's demystify these. This is a book that we should all have access to, and then get familiar with there is a method to the madness. Why there is no code for adjacent segment degeneration mystifies me, but there isn't either cervical or lumbar, and why there isn't a spondylolysis or there's a spondylolysis code, but there should be a better. I'm not going to criticize ICD-10 the whole time, but it should be the degenerative spondylolisthesis should be very well distinguished from spondylolysis or isthmic pars. We don't have a breakdown in that with ICD-10 with everything it has, but there are some good things. So chapter 6 is where we are going to live, along with chapter 13. And then for trauma, we're looking at chapter 19 and 20. That encompasses everything you need to know for ICD-10 and spine. Those 4 chapters. And so we'll go through a couple of these. So you can see how easy this is. There's method to the madness. So you do not want to use site unspecified. 50 or M43 TAC 10 is general cervical spondylolisthesis. But if you have it at occipital cervical, if you have it cervical, you have cervical thoracic. These are the ICD-10 codes that you'll be using. And so it's a nice code to be using for, especially now Medicare has prior authorization requests, and you can see that there's spondylolisthesis at some of these segments at the cervical thoracic junction where the signal change abnormality resides. And so in this case, I'd be using M43 TAC 13 as part of my prior authorization. Right there. And so there's all of these are very easily found with your ICD-10 book. Okay, so spondylosis with myelopathy. This is going to be an individual who on MRI is going to demonstrate, obviously, well, I mean, myelopathy is a clinical diagnosis. And so they have a Hoffman's, they have a gait abnormality, they have wasting of the hands. When it's at the occipital cervical junction, it's going to be M47 TAC 11. The most common one that we use is cervical myelopathy, M47 TAC 12, and then the cervical thoracic, which you just saw. That's for myelopathy when you see something referable to that exam. So in this case, this patient has good old-fashioned cervical spondylosis with myelopathy. We're not seeing the MRI, but on the exam, to be consistent with what we're using in our codes. We want the codes to reflect the clinical history and the neurological examination. If I see that code on something that patient that I coded gave that diagnosis to, I would anticipate that their exam reflects that and their imaging reflects that. Radiculopathy, so this is there's a set of codes that are the M50 codes that I prefer to use, especially when there's not a significant amount of spondylosis. Those are my artificial disc type patients. But these are going to be the codes that I'm going to be commonly using. M47 TAC22 is a very common code that I use almost every day in clinic in someone who's got advanced degeneration. So stenosis, this is going to be a patient who may or may not have myelopathy, but they will certainly have, this is a radiographic identifier. This is a stenotic patient, as you can see, with an M48 TAC02. And you can see that when you're at the occipital cervical junction, you're at 0.1, cervical 0.2, cervical thoracic 0.3. So this is how I would be using that. So this is all of the codes that are very commonly used: stenosis, spondylosis, radiculopathy, myelopathy. What about the M50 codes? So these are the codes that I would be using in patients who don't have a lot of spondylosis or very little spondylosis. For example, these are patients who I would be using these codes because they're going to be motion preserving type of procedures that I plan on doing. Kyphosis, typically secondaries because they've had previous laminectomy. Postural is just time and gravity, unspecified M40. But if you're planning an extensive reconstruction on someone, it's not going to make a lot of sense if they just have cervical stenosis or cervical radiculopathy. You're going to want to add a kyphosis type. So this is someone who has kyphosis. This is obviously from trauma. Secondary, there's a disruption of the posterior tension band, and this is someone who was being treated non-operatively for that fracture that subsequently went into kyphosis and then had to have a correction of that kyphosis. This was a young individual. This is someone who's got cervical thoracic kyphosis. The construct just did not go far enough for this. This is my patient who should have had a much more extensive reconstruction of the neck, but then the cervical thoracic, so that was the M40 TAC13. So review of the common codes here. Cervicalgia, that's basically because you haven't seen the patient yet and they need to get x-rays before you see them. That's the only time I use that code, because my staff will put that code in so they can have an indication to get an x-ray. The rest of them, spondylosis with radiculopathy, spondylosis with myelopathy, and then radiculopathy. One of these should be, yeah. That's going to be without radiculopathy or myelopathy, basically meaning that they've got a bad looking x-ray, but they just have neck pain. Okay, so that is a quick fly through the ICD-10 codes, which again, these are the codes that are valuable to have as you're doing your prior authorization. Now let's do the same thing with CPT. CPT stands for Common Procedural Terminology. And this is, it's owned by the AMA. It came out in 1966. It was to figure out a way to pay physicians for what they do. And then someone came up with the RVU, which now is the law of unintended consequences. And we are married to CPT for the rest of our existence. So what are the common codes that we are going to be using? Okay, well, we just think, let's an ACDF. We do multi-level ACDF. We do foraminotomies. We do a laminectomy. We do a laminectomy with fusion. If you guys can understand this and get an appreciation for this, then all of a sudden life is going to be a lot easier when you start your board collection and have to submit these codes. You do not want to be giving a reviewer the excuse of saying, I don't do my own coding, because obviously all of us are responsible for our own coding. And you don't want to say it's the hospital coder gave me these codes, because these are things that are not helpful, especially if 10 years from now, no IG investigation happens. We're ultimately responsible for all our own codes. So the most, what we want to do is distill the procedure down to its core elements. What are we doing with an ACDF? You're doing a decompression, then you do the instrumentation, and then you're going to graft. The decompression codes, I call these the zip codes. The decompression codes live in the 63,000 family. Arthrodesis codes, whether lumbar or cervical, are going to live in the 22,000 family. Instrumentation codes, non-segmental, segmental instrumentation, you're in the 22,800 codes. So 840, 842, 843, that's multi-level. 841 is a wiring code that we seldom use. And then your bone graft codes. Then you're going to be localizing them by cervical, thoracic, and lumbar. And then we always have our add-on codes, the 69990, which is bundled a lot of the time, and then computer-assisted navigation, the 61783 for anyone using navigation, and that seldom, unfortunately, gets paid. So instrumentation codes, 22840 and 22842 are by far the most common codes that we are using. Deformity guys are using 22843, and I've never used the 22844, and I hope never to use the 22840. It's the number of levels that we are including in the construct. Anterior instrumentation codes 22845 and 46 are the common anterior cervical ones. These are rarely used anymore in the anterior lumbar spine. There is a definition that has to be met because using, for example, there are standalone interbody technologies that if a plate is not separate and distinct from the interbody spacer, then it does not meet criteria to be used for an anterior instrumentation code. More examples of that to follow. And then we have the 22851, which predates probably a lot of you. I think it was 2016 when that code split. 22853 is going to be the common interbody code that is used if you're doing a corpectomy. 22854, if you're doing a corpectomy without the intention of fusion, which was the whole intent of the 22851 to begin with years ago, then you do 22859, for example, if you're doing something for cancer. We'll skip this. That's just the fact that how codes, where these come about, but I don't want to spend time here. The descriptors. Then the bone graft. So obviously, as you go up, the amount of work that you do increases. So you start with a 20930, and that is someone opening a container and pouring a bone graft onto the field for you to use, versus a 20938, which is where you are using a separate incision and harvesting tricortical graft from the hip. And then there's all that stuff in between. If you're just taking local autograft, it's 20936. Okay, so when you're doing this, you want to make sure that the ICD-10 procedure or the ICD-10 diagnosis makes sense for what it is that you're doing. Then you want to know, did I do an anterior approach, posterior approach? What levels did I approach? Did I decompress? Was there an arthrodesis? And was there instrumentation? And then you choose a standalone procedure for the decompression discectomy. And then C12 has its own codes. C12 arthrodesis is a completely different kettle of fish. Odontoid fractures are very specific. So those are not going to be covered in this. That's a little bit, there's more coding resources on the INS website. And so we should go into going into these common codes. So anterior for your anterior cervical discectomy, you would use a 22551, and then for every additional level you do that's the plus sign. The plus sign, and when you see that in your CPT books, and everyone should, if your department should have access to a CPT book, the CPT books when you become familiar with them, you'll notice that the plus sign means that it's an add-on code, because you cannot use the 22552 alone. Doesn't make any sense. You need the 22551 as the first code, and then as you do a 2-level, 3-level, you use the subsequent codes there. Corpectomy, 63081, and then the 63082. That's going to be a lot of corpectomy if you're doing that. Typically, it's a single-level corpectomy, and then you have the arthrodesis above and below. We'll have examples of that if there's time. This is for the laminectomy. Laminectomy codes. This is if you're just doing a trough laminectomy. This is 1 or 2 vertebral segments. Remember, everything's a functional spinal unit, meaning a level above, level below. When you do laminectomies, we don't do a laminectomy of L4. You're actually doing a laminectomy to decompress the L4-5 level. So that's been an area of some confusion, because even if you are removing part of the lamina of L5 to decompress the L4-5 segment, it's not, you're not including all of these levels to do it. So, but one of the common areas of concern is when you're doing a trough laminectomy, the lobster tail, as I call it. We are not doing a laminectomy at every level because we're not decompressing the nerve at every level. You're doing trough laminectomies at 63015 covers that. This is a 63045. That's if you're actually going out and doing a decompression of the spinal cord and the nerve root for a single vertebral segment, cervical, and then if you're doing multiple levels, 63048. All of this will make, and this is just if you're doing a decompression. So I want to be able to show you some examples before I yield the floor to Clemens. So let me see, hopefully I have this thing up, and then we'll go through some examples. And then I'm going to stop share so I can figure out where this thing is. Okay. That is a lot. Is there any questions on that, or is it better to get to the cases? It's like drinking from a fire hydrant. Okay. All right, we're just going to go through some examples. My disclosures have not changed. Okay, so now I want you, Robert, Rudy, to be you're now your first day in clinic and you're an attending. Now you got to get prior authorization. All right. So this is the cases that we're going to go through, and then we're going to go over to Clemens' vascular talk or cranial talk. So we're going to look at single level ACDF, multiple level ACDF, single level arthroplasty, 2-level arthroplasty, and a posterior cervical foraminotomy, and then we'll be done. So we're going to do that hopefully in about 10 minutes. Remember, we did all this, so we're going to review some of that stuff. So case one, because I think spine is always, well, everything is always best done in case illustration. So here we have a 45-year-old right-hand dominant flight attendant, 4-week history of left radicular arm pain and axial neck pain. Whiplash injury during time of landing. So guess what? Workman's comp. That's a whole different talk in and of itself. Tried all the physical therapy, epidural injection, cervical traction. Now is on short-term disability. 4 out of 5 on the bicep. 5 out of 5 on the left. Everything's pointing to a C6 nerve root. No myelopathy. There's a nice X-ray. There's the disc. There's the herniation. So first of all, you want to get the prior authorization. You want to get this done through workman's comp. So what are we going to do? We're going to get the right diagnosis here. And in this case, the correct diagnosis that I think is going to be best for this patient is going to be the M50 codes. So that's M50 TAC 122. You can use this, but I don't think there's a lot of spondylosis. So M54, these are the most precise codes. So this patient ended up underwent a fusion because of abnormal flexion extension X-rays. And so I did not do arthroplasty on this one. So how do I code this? So remember that 22551, this is the arthrodesis. So this is the first level. Then I've got a 22845. And then in most insurances, you use a 59 modifier. We're not going to get lost in the weeds with a modifier, only to say that when you put a modifier on the 22845, you are basically saying, I used a plate separate and distinct from the interbody spacer. That's something that it's a nuance that you have to add to communicate to your payers, because they will default to not wanting to pay this because they'll think you did a standalone, because it's money that they don't have to pay, and they never are looking for a reason to pay you more. 22853 is the interbody. That's the interbody spacer. So that little guy right there, the fact that it's not bone means 22853. Difficult to get that approved with certain commercial payers. 20936 is because everything that I drilled, I collected, I placed it into that spacer along with some more sliced allograft. And these are all my codes that I get to submit. And then hopefully 70% of the time I'll get paid. The other 30% of the time it'll sit in denials and need to go through appeals, even with the prior authorization, which is why we're all here in the CSNS, because they're trying to fight stuff like that. So this is it. 22851, 22845 with a 59 modifier to say that we used a plate separate and distinct, and that is a plate separate and distinct, 22853 and mortualized allograft and autograft. So that's actually allograft, the 3.6 is the autograft. So that's the first one. This is not hard stuff once you get to it. So if you're using structural, then you lose. Okay, so this is an example of a patient who had Aetna. And if you have Aetna, you do not get to use peak. So you have to use this or they won't pay for anything. So this is a structural allograft. So the difference here between this case is the 20931 because that's structural allograft. Here, the placement of peak 22853 that allowed for that. Single level ACDF. Now this is someone who had a standalone interbody spacer. Can you use the cervical plate code in here? Dr. Rudy, can I use it?
No.
I put screws. Look, this is not easy to put this all the way up there under the jaw and get the angle there. That's instrumentation. Doesn't it meet criteria?
No plate.
No plate. It's not separate and distinct. Everyone bickers about that. Okay, so that's the summary. ICD-10 code, radiculopathy, codes. All right, let's do this is now with spondylosis. So this is an individual, looks like the Romberg negative, weak, they have a positive Sperling sign, shoulder, so it's all radiculopathy. That's a bad looking neck. I would not use the M50 codes here. I would be using something because this is a pretty advanced spondylosis. No myelopathy, but with radiculopathy. Cervicalgia is a weak code, but it's not I mean, you can still use it. Cervical, it just doesn't help. Cervical radiculopathy doesn't lay the groundwork. So in this case, I would be using the M47 TAC 22 code. And that would help me get my authorization. There's a radiculopathy code, but it excludes, so you don't use it in combination. So I use these codes for submission. These are when you go, this is pictures from the ICD-10 book, and this is the exclude one code, so they don't want combinations or anything that has redundancy. So all you would use for this is M47 TAC 22. And so this is the procedure that was done. So this is now pretty easy because you already know the 22551 and you know the add-on code 22552. So here it is, 22551, 22552. We got a plate and I dictated it's separate and distinct from the peak interbody spacer. And then this you can just put multiple units times 2. You can use a 59 modifier. I wouldn't get lost in the weeds on that one. And then everything I drilled, I collected, and then I had them open up the allograft, and we don't get paid for these anyway. So these are the codes that we would use for the 2-level. Any questions on that? Makes sense, right? This is, those of you who are not coding can clearly see how this is not hard to do and something, you know, you got to do it eventually. You might as well start tinkering with it now because you don't want to be in case collection and not being able to do this. Okay, so this one is a 30-year-old firefighter who says, I don't want a fusion, I want an artificial disc. So I had a drywall collapsed on his head. I remember him. He comes in with the arm up like this, and where is he? He's got this nice disc, and he wants an artificial disc for this. I don't know. So this is going to be the cervical thoracic radiculopathy, or I can use this, and I like that code because you have to use one or the other because of the exclude. All of this you become familiar with when you start looking at these codes in ICD-10. I did not do an artificial disc. I did a posterior cervical foraminotomy, and because I did a foraminotomy with discectomy, I'm going to use the 63020 with the use of the operating microscope. That was when I got authorized. That's what I did. Did it at a surgery center. Done. So these are the codes. And this is because I was removing a soft disc. The disc drives the code, so it's from raminotomy with discectomy. That's why I use 2-0. If I was doing a bony spur that I was removing oncovertebral spurring, I'd be using 63045. But okay, so then we're going to wrap up with arthroplasty because I want to be sensitive to the time. 42-year-old nurse, radicular arm pain after a 350-pound patient a month prior. Injection made things worse, cannot tolerate physical therapy. Absence C7 reflex, shoulder abduction sign, positive spurling, and a profoundly weak tricep. Very fit person. She likes doing push-ups. She can't do a push-up. You can see that she's kind of leaning forward. And this is her MRI. And this is a hyper intense disc. So she can actually does have normal imaging. She just, her neutral imaging is positive because of her radiculopathy. So she's got a C7 radiculopathy. So I like that M50 code, which is spot on, and also because she's going to have an artificial disc. So this is the procedure that was done. When the artificial disc was evaluated, we have to be very careful not to decrease the value of our other codes. So guess what happened to the 22856, which is the only code, includes microscope, includes discectomy, includes decompression, includes everything. Placement of it, it's one code and has less value than the single level ACDF. And then you would say, well, that's a problem, but in reality, the goal is to maintain the value of the codes that we presently have. So everything is horse traded. So that's the difference. If we did a fusion, we would use all these codes, single level artificial disc, we use one code. I think that I am at the top of the hour. And so I'm going to yield the floor to my colleague from Pennsylvania, Dr. Shermer. I'm happy to entertain questions if anyone has any questions. Rudy, you doing any of your own coding?
I'm not doing any of the coding, but they want us to try to think about the codes in clinic ahead of time.
What about in surgery when you're actually using the codes? When you walk into a surgery, do you say, these are the codes that I'm going to use? If I had to code this.
I haven't been doing that.
And the reason that's important, Robert, I'll tell you why, is because when I dictated my cases just now, the first thing I'm thinking about is what CPT codes I'm going to be using, because my descriptors need to nail my description need to match my CPT codes. So I have to think about that. Is any of this stuff foreign to you? Is it old hat, familiar?
I wouldn't say it's foreign, but it's definitely not something I'm like super familiar with at the same time or anything like that. It's concepts that we hear a lot, but not
And
something.
I'll call on Dr. Still because everyone else has their camera off, so I don't even know if they're there. Dr. Still, any thoughts on this? Is this familiar to you? All foreign, new?
It's pretty new, but we have to dictate our own notes at the VA, which I've been on for about a month. So I'm starting to learn this concept of the integrating like the CPT codes and the ICD codes. But we don't use the actual code numbers. We just have to use like the descriptors. And so I'm still not as familiar with like the number families.
So there's the old adage, and I do subscribe to it, that you do not dictate CPT codes into your op note. That's an old adage that we have. Just describe exactly. Now my descriptors basically are describing the CPT code, but we do not dictate CPT codes into there. I see Dr. Zeichman. Dr. Zeichman, you do any of this?
At least a template. I think it's auto-populated in the Epic op note.
Is it accurate?
Sorry?
Is it accurate?
Um,
When I hear the word auto-populate, I say, what could possibly go wrong?
I do look at it when I write my op note, and it, if there's a discrepancy, I usually bring it up.
So you have to write your op note, not dictate it?
Yeah.
It's all like kind of the Epic template?
Mm-hmm.
So I'm reviewing a huge lawsuit with regards to coding malfeasance with Epic auto-populated op notes. Careful out there. They don't
So
let you dictate.
how do you guys book the cases? Like, what do you tell the front desk? Do you give them codes, or do you just give a like verbal description of the case?
Everything here is a verbal description of the case.
For
We
us?
actually we do give the CPT and the ICD-9 codes when we
ICD-10.
book. Sorry, ICD-10 codes when we book cases that come through as call, but we don't book anything coming from clinic.
But do you just give them so like the biggest one, if you will, or do you actually have to, go into some details there?
We go into some details, but I'm not sure how well we do it.
And Sarah, is it all this stuff old hat to you? You guys, I'm always curious what the coding IQ is of our residents.
I don't think that my program's fluency is that great. We've created our own forms that have maybe 20, 25 different options that are kind of our like highest yield codes that we end up using the most frequently, but I don't think that I certainly don't appreciate or understand a lot of the nuances.
All the
Was this
work that
helpful?
Jill did, that is all forgotten.
All
Anyway,
right, we're Clemens, take it away.
super. So, I sort of didn't read the assignment very well. So I apologize. I actually wanted to talk about something else, but I don't think we're gonna have time for like a little bit of an overview of like how we got here. So I'm gonna do two things. One, maybe step back a tiny bit, going back into let me just make sure I'm pulling up the right one here. Where Dr. Toomey Allen like started. Can you guys see this?
Yes.
Yes, great. Basically ask why should we care in the first place, right? And we have talked through a couple of the points. There's the obvious reasons, right? Eventually you want to be paid. I know all of you want to get out of residency, take a good job, and eventually have some kind of like take-home pay. And this, for better or worse, is the system of how we actually get paid, unless you completely like leave this and just, I don't know, take cash, which is certainly possible, but not really practical. If you zoom out a little bit, there's this aspect of financial viability and practice sustainability. There's, of course, compliance, legal protection, professional development, and essentially just like presenting your value proposition to whoever you're working with, your practice, your partners, and perhaps like your hospital system if you're one of the few employed people that seem to be growing, by the minute. And then if you zoom out a little bit more, good coding actually brings together a certain framework of a patient-centric approach or a healthcare system-centric approach, because it improves transparency of what actually happens. If you actually engage in good coding, it reduces the financial stress on patients, because it means that theoretically patients are able to compare and contrast what you're going to do. And this has a whole impact on how we talk about prior authorization, which we're not going to talk about here today. And this like feedback loop of how we actually book a case, and then get the case done. And then, of course, it eventually will address some systemic insufficiencies in the healthcare system. And I really like this video that Dr. Glockenflacken put together, where he basically scalding all of us that you don't learn about the US healthcare system when you're in medical school or later on. Since this is a CSNS fellowship that you guys are in, I just want to make sure that, to like calibrate where we are. as a convening body of issues related to billing and coding, right? So we don't make the rules, but we want to engage in the rules and make sure that the rules are pertinent to neurosurgeons. There's a little bit of a grassroots effort. We want to hear about changes in payer policy, have like a quick reaction task force around these kind of issues. But we also want to be a deliberative body to give input to the parent organizations and the joint Washington Coding and Reimbursement Committee that both Dr. Timmy Allen and myself belong to, and is currently chaired by Dr. Vates, and is really like the true convening point in neurosurgery for these issues. So moving on for this a little bit, there's a bunch of acronyms that were just thrown around, and I'm sure you actually know all of these, but it's probably worth like, again, stepping back a little bit, like, why do we care about this, right? There is this documentation divide between the payer view of a patient and your view of a patient. And, you know, the way this is bridged is in general with ICD-10, and I'm sure most of you are familiar with the ICD-10 diagnoses codes, but some of you may have heard about the PCS or procedural code universe and its dimensions. So that's a 7-digit string of alphanumeric signifiers. Basically they talk about like the body system, the root operation, which body part did you use, how did you do it, what device did you leave there, if applicable, and what qualifier that is. And it's important to understand that this is not the same as CPT codes, which is like the physician-centric work description that we typically talk about. But it is a very important way of like talking about what we do in the setting of the inpatient space, or anything that has to do with the hospital. And I'm sure all of you may have heard about the DRGs, so the diagnosis-related groups, which is like a way of bucketing these PCS codes together and decide about average payments for these. The reason that this is important to understand this at least a little bit is that there's sometimes a discrepancy between how the same thing is being described in the ICD-10 universe and the CPT universe. For example, if you do a thrombectomy and you have essentially like an unsuccessful and aborted procedure, you dictate something to the effect of that you've vascularized or revascularized the vessel with a suction catheter, but no clot was seen. To me or to us or to everyone, that looks like a pretty successful procedure. The question is this a aborted thrombectomy? Because you didn't take any thrombus out, right? Is this unsuccessful? I guess it is successful, right? You revascularize the whole thing. Or is it successful, right? That distinction will drive what DRG will be assigned to this, and it will obviously drive the payment for this procedure. And, sometimes this is a source of confusion between the inpatient coders, the outpatient coders, and the physician coders that all are trying to look at the same operative note and decide what is the most appropriate thing. And, maybe piling on to what was just said, that when you dictate or type out, use your templates, your notes for the operation, you got to think about like what's the intent behind this, and like how do you actually convey what you did in the best way. Now, I'm going to basically say that you got to think about multiple universes here, because you got to convey clearly what you've done in the most beneficial way for all of those things, because somewhat, if you don't do this somehow correctly, you will be penalized in one of those universes, and someone will come after you and basically tell you that this is no good what you've been doing. This is a little bit of a complete change from what we typically hear about our physician side, and it's definitely something to like learn about a little bit. So going back to this thrombectomy example, for example, to make this more tangible here, if you basically say that you took the clot out but you didn't see it, that may be enough for your coder to essentially say, okay, fine, I get it, that's a thrombectomy. But if you just basically say, I didn't see any clot, I didn't take anything out, then they're basically going to dictate, I'm sorry, they're going to code for a diagnostic angiogram because that's all they can find in the equivalent of this procedure in the ICD-10 PCS space. So do you have to worry about everything? You sort of like do. And to maybe now move a little bit on to the specific content of this, the remaining 15, 20 minutes here, and we'll see how far we get. I just want to touch on the principles of cranial coding. This is not going to be a cranial coding course. We would need a little bit longer time, but it's probably worthwhile to go through these principles here. Cranial coding is actually really simple because you can describe pretty much every procedure that we do with this kind of scheme or this grid. You need to find the primary craniotomy CPT code that is typically chosen for this procedure. And it's not just about the approach or the craniotomy sometimes. We do have different CPT codes for a primary pathology or diagnosis. So in other words, there's a different code for a meningioma versus a intraaxial tumor, but we distinguish between a supratentorial and infratentorial approach. So typically there's some sort of 2x2 or 2x3 kind of distinction between the approach, oftentimes between super and infratentorial, as well as the primary diagnosis or the complexity of the particular base operation. One, if you will, different way of thinking about this are the paired skull base codes, where we very distinguished or explicitly distinguish between the approach and the resection code, and then also have a option for a secondary closure code. And the background to this is really that this is meant to be used by different physicians. This is team surgery between, let's say, a neurosurgeon and an ENT colleague. And therefore, we design these codes in such a way that each surgeon can just simply claim their own CPT code without having to deal with any shared modifiers or any other acrobatics around sharing an operation. The second big question is always for cranial codes, is the microscope being used for not illumination, but the keyword in your operative note should be microdissection or something like that. Followed by, is stereotactic navigation being used? And then, was a ventricular catheter ICP monitor placed through a separate twist drill or burr hole? And by separate, we mean a separate skin incision, not a separate hole just at the edge of a previous or otherwise created craniotomy that you're doing in the same operation. Did you place a lumbar drain as a different version of this? And these all have different CPT codes you can add on to your base operation, of course. If you have any kind of graft material that you're harvesting through a separate skin incision, abdominal fat, fascia lata, you can bill for this and code for this. If you just take it from the same incision, the periost or something like that, that doesn't count. That is built into your approach or your closure, if you will. There's a couple of extra codes for intraoperative MRI for those of you who have this. There's a couple of extra codes for intracavitary chemotherapy, as well as cortical or subcortical mapping for some epilepsy resective type of procedures during an awake craniotomy. If we go to the endovascular scheme, there's different questions, but it's a very similar way of thinking about this. So for one, you start with, is there a diagnostic angiogram that is performed, but also is it appropriate to code for this? And the key question is here, is there a pre-existing diagnostic angiogram that has the same information in it? And the key word here is pre-existing, but also same information, because if the diagnostic angiogram was done yesterday and the patient's condition has changed, the information that is contained in that angiogram is clinically no longer relevant. If it is something that was done, 3 months ago, and the patient literally hasn't changed and is now showing up for their definitive procedure, that diagnostic angiogram may contain all the clinical relevant information, and it is actually not appropriate to bill for another diagnostic angiogram. Secondly, do you use an ultrasound for localization or assessment of the artery that you're accessing for vascular access? Did you do an intervention? Is there a separate or a bundled intervention code? So to make a big example, intracranial embolization is a separate intervention code that is not bundled. But for example, a carotid stent is a all-in, or intracranial stent is an all-in bundled code that includes everything from stem to stern, access, diagnostic, angiography, and everything else. There's a couple of legacy supervision interpretation codes. This is a remnant of a different coding scheme that comes from radiology that is basically being phased out over the last couple of decades, but there's still some codes that exist. And then is there 3D imaging that you performed, as well as did you do any moderate sedation by yourself and documented all that, in which case you can bill for that. If you use a microscope, good documentation, as mentioned, is to be talking about microdissection, not so much for, bringing it in, elimination, magnification, anything like that. And of course, unfortunately, it is bundled into a lot of the things that we do, namely things like in ACDF, pituitaries, nerve repairs. So you can use it all you want, but you can't separately bill for it. You should still, however, actually document that you did use it for all the other reasons that I mentioned before that documentation is really serving. Stereotactic navigation, there is intracranial, extracranial, or extradural, I should say, as well as spinal, which I'm not going to talk about here. And the key word here is actually not to describe what you did when you registered or when you put the star on or something like that. The key word is really to describe what you did with the pointer or with the navigation while you were doing the procedure. Like, is it something that you're actually doing intradural navigation with, or is it just something that you use to like point on the skull and do a craniotomy? And then let me just move on to this a little bit more into supravascular coding in particular, because, this is like very illustrative of some of these examples, and we'll just go through this a little bit before we stop for some questions. Endovascular coding in particular has been evolution of a legacy component coding framework to a bundled code, both for diagnostic and interventions. And these are the general principles that I just outlined again. But the other general principles here is that we have different vascular territories to remember. And this is a little bit the equivalent of supratentorial, infratentorial as a coding framework for any cranial codes that we use. So to make an example of a diagnostic angiogram, so this is a patient with a TIA. The ICD-10 code for this is I67.1. And as I mentioned before, you need to demonstrate that you need to actually do this. So there's an indication for this. Medicare considers a prior study, a catheter-based study, or a CTA. So you kind of have to explain in your indication for the procedure why that CTA that may exist from just 2 hours ago is no relevant or not relevant enough to give you all the information that you need. And there's, of course, a lot of clinical reasons why that may be, but you have to be a little bit explicit about this. So this is a typical diagnostic angiogram. You essentially catheterize a bunch of vessels, you do some imaging there, and then you close. And this is really all included in the work that is being described by these codes. What is not, or what is separately looked at is, where did you place the catheter and where did you actually do your angiogram, or what did you assess? If you place your catheter in the common carotid artery, for example, versus the internal carotid artery, that's a different code, even though you may be looking at the intracranial circulation either way. Same thing goes if you do a 3D reconstruction, you can add that on. Extracranial circulation has a separate code, but you need to make sure that you're actually placing the catheter in those. And this is kind of like how this looks at the end of the day. If you do bilateral injections, you give them a 50 modifier for left to right, and some payers actually want to have the RT and LT modifiers for this. You can do some separate things here if you have a diagnostic test that is separate. And as mentioned, If there's any kind of like changes that are relevant, you got to document that there are clinical changes that require the use of another angiogram to figure things out. Moving on to our most favorite procedure these days, a thrombectomy. That's an example of an all-in bundled code, regardless of what you do. The main key or the main challenge here is to be specific for the ICD-10 code as to what kind of universe you use here. The keyword is to look for embolism, maybe more so than thrombosis in your coding book or your coding scheme. And this is, of course, like a general way of doing this procedure that is pretty standard. Everything is included as mentioned. So it really doesn't matter how you do this. This is how this should look like, ideally speaking. And then the code for this is simply a 61645 that includes everything. Flow diversion is the opposite. This is essentially a way of modern use of the legacy component coding system. Just to go through this really quickly, this is not coded with an intracranial angioplasty or stenting. This is coded with an intracranial embolization because that's the intent of the procedure, that you're embolizing or getting rid of that aneurysm rather than stenting the parent vessel. Even though that is, so like functionally what you're doing. And this is how you would code for this. And because the embolization code 61624 is only describing simply that activity, you can bill for all the placements, all the selections, as well as all the potentially required diagnosis or diagnostic angiography if you don't have one from before separately. So it depends on where you're coming into this in your procedure. You may be able to bill for a number of these things. If you now go and clip an aneurysm, I know that still exists, then you have choices, along the lines of what I outlined before. Do you do, for example, your EVD in the OR, in which case you might want to use a burr hole through a separate incision? That would be 61210 with a 51 modifier to essentially unbundle or say specifically that this is a separate operative field. And then, as mentioned, the distinction for aneurysms, is it simple or complex? And for simple aneurysms, for complex aneurysms, some basic criteria are if it's pretty big, more than 15 millimeters is usually accepted. If it's calcified, if it incorporates normal vessels, or if it requires a temporary vessel occlusion trapping or cardiopulmonary bypass. And if we now go to, do this, you may, for example, use an ICG angiogram to look at what you just did. That is not a real angiography. You're not catheterizing a vessel. You're not injecting dye. You're not using radiation to visualize this. So that is, for example, built in, doesn't matter. If you use an ultrasound or some kind of flow probe, same thing. That is all built into what you're doing there. There's no separate coding for this. This particular example, you would use a 61697 as well as 61210, as mentioned before. And then if you do an intraoperative angiogram, like a real angiogram, you can bill for that. Because again, compared to what happened before, your clinical scenario has changed. You just clip the vessel. You want to make sure that that vessel, that parent vessel, is okay, and that you have gotten rid of the aneurysm in the way that you intended to. And then of course, those patients go into vasospasm. There's a whole code family for this. I'm not going to belabor this too much. If you have an AVM, you essentially apply a similar way of thinking around this. You may do a diagnostic angiogram. You may do a preoperative embolization that you can describe the way we just talked about for aneurysms. And then you can resect this AVM. And again, there's different, there's like a 2x2 grid now for supratentorial, infratentorial, simple, and complex. There's also two other codes for dural AV fistulas for open disconnection there. You can use these codes also for cavernous malformations, even though that's a little bit maybe controversial, but that is okay. That's how you just step through this. Carotid angioplasty and stenting, as mentioned briefly before, that's an all-in code. The only distinction is here whether or not you use a distal protection device or not. And the rules about carotid stenting are mostly about coverage, that you have to fulfill additional criteria to essentially document that this is an indicated procedure the way Medicare wants to see it these days, or other payers. So you got to look a little bit into the details there. All right, so I want to just maybe stop here because maybe there are some questions, and I already see my comment box blinking, so let me go there. Any questions about this?
So you guys are drinking out of a fire